All right. Hi, everyone. On behalf of the SIR Medical Student Council and Vascular Interventional Radiology Interest Group Committee, welcome to our DO residence panel. Thanks for joining us and taking the time out of your busy weekends, especially if you're a fourth year getting ready to send in your application. My name's Andrew. I'm fourth year at Toro in California, and I'll be moderating this talk with Eric and Oleg. Today, we're joined by an awesome panel of DO residents, and they are pursuing IR either through the integrated pathway or the ESIR pathway. And we'll be learning a little bit about their experiences in pursuing IR as a DO, or any of those and it'd be helpful to us as DOs or anyone who is at a medical school that doesn't have a home IR or DR program. Here's an outline for the talk. And at any time, feel free to throw your questions in the chat. We'll be trying to answer questions as we go. And without much else to do, we'll have the panelists introduce themselves, and we'll start with Millie.
Hi there, my name is Millie. I'm a PGY4 here at Loma Linda. I am an IR integrated resident. I went to Western University for medical school and ended up staying in SoCal.
Hi everyone, my name's Navjit Dullet. I went to Toro University, California up in Vallejo. I'm currently a ESIR resident, PGY4 at the University of Arizona.
Rina's on call, right? Hi, my name's Sagar, Desai. I'm a PGY2 integrated IR resident at Albert Einstein in Philadelphia. I went to PCOM, Philadelphia College of Osteopathic Medicine, so I stayed local for residency.
All right, thanks guys for introducing yourselves. Just to give you a second to introduce myself, my name is Eric Nelson. I am a third-year medical student from Western University of Health Sciences. And so we got a lot of questions about from people in our audience right now about, they basically want to know what is it about IR that made you want to choose this career path? Things about like, how did you first get exposed to this field? Have you considered other specialties before you chose this one? And if at any point you're unsure about IR, like what were those moments that made you decide that IR is what you wanted to do? And so I'd like to start this off by directing this over to one of our panelists, Sagar.
So coming into med school didn't really, M1 year didn't really have an idea about what I want to do. M2 year, studying like just day in and day out for boards. I thought that was very analogous to like diagnostic radiology. So I thought something that, you just go in, do your work every night, you're like at a cubicle and leave for the day. That sounded well. When I started PGY3, I got some operative experience. My first rotation was OB-GYN, so I thought, surgery was a way to go. Where I got interested in IR was I went to an IR symposium at Penn, October of my MS3 year, and I was sold after that. I was 100% in. Asked my school to give me 4 weeks of IR as my subsurgical specialty. So that was a good exposure. We don't have a home institution, so I coordinated that with the local hospital. So yeah, I guess, diagnostic radiology and surgery were on my list, which is kind of, I guess, cliche for IR, but yeah, I think the IR symposium really helped out for me. That was an eye-opener.
And so Sagar, what were some of the things that pushed you from surgery to commit to IR?
I think one was it's limitless, the exponential growth right now in the field, and like every different we were just talking before about the MSK interventions, and I've been interventional oncology, a lot of stuff is up and growing, and I didn't see that kind of growth and passion for surgical procedures personally. So that was a big driving force. And also you always have, you know, depending on what you want to do down the line, you always have a chance to read diagnostic film, do, you know, a hybrid job or what have you. And I liked that freedom as well, because I still do like diagnostic radiology. The other thing I'd say is I think the varying breadth of IR at each hospital and each hospital system based on referring patterns or, you know, the skill set of whatever interventional radiologists are in a group vary everywhere. So, you know, you have a different flavor of IR every hospital you go to. And I thought that's very unique. I don't think any other field can say that.
Sounds good. How about you, Navjit? Any thoughts on this topic from you?
Yeah, sure. Actually, you know, I think these medical student symposiums and trainee symposiums are just incredible. And that's actually, you know, in a way, it's one of the ways that I was actually exposed to the field as well. You know, I went into med school, you know, not really knowing necessarily which direction I wanted to go into. You know, I have a family who's in cardiology, electrophysiology, as well as interventional. And so, you know, that was my primary exposure to medicine prior to medical school. And I thought that field was really incredible. And actually, that's kind of started my interest in image-guided procedures. You know, as I was going through, one of the nice things about Toro, California is that we had pretty early exposure to imaging in our anatomy lab. And so, you know, we had one of the really nice things that we had was opportunities to get hands-on experience with ultrasounds. And so we, you know, would scan each other, do, for example, you know, abdominal exams, take a look at the, you know, the liver, et cetera, kidney, shoulder, actually, even you know, musculoskeletal applications. And so, you know, I just thought that was really neat. You're making diagnoses in a non-invasive way. And, you know, I have a bit of an engineering background, so, you know, that side of imaging kind of really appealed to me. Now, where it really kind of the interest grew was actually doing a rotation at Kaiser LA. And, you know, one of the things that, you know, I did do an IR rotation during my third year of medical school, but it was at a community practice, a little bit more of the old school way. So it was just kind of doing the procedures and kind of jumping from one to the next. I didn't really have necessarily the clinic experience, didn't really have the patient interaction that I kind of wanted in medicine. And so rotating at Kaiser LA and actually going through the additional, you know, other academic centers during my fourth year elective rotations, you know, that really just kind of drove the interest and, you know, made me realize the potential of interventional radiology. I just love the fact that it almost can touch every single organ system, you know, from head to toe. And I just found that incredibly rewarding. You know, actually, and that's kind of continued through in residency. You know, we continue to have resident clinic, and so just following these patients up is actually really great. You know, it's funny. I had clinic 2 weeks ago, and then the cases were coming in this past week, and so I got to see a couple of the patients that we worked up in clinic, and I got to perform the cases, which was actually really rewarding. In terms of other fields, you know, to be honest, I wasn't, it's kind of interesting. I wasn't really considering surgery. So I guess I'm a little bit different in that way. I kind of had the interest early on in radiology pretty much from third year, and then just kind of shifted more towards the interventional side.
Very, very nice. How about you, Millie? What was kind of like your first exposure to IR?
Yeah, sure. So I had no idea what IR was before med school, and I had essentially randomly found out about UCLA's IR conference. And so I had attended this during my first year of med school, and that essentially piqued my interest to IR. You know, I was really curious about, I loved how creative the procedures can be. And to me, it seemed like a good balance between procedures and patient interaction and imaging, that's kind of the feel that I got during a 3rd and 4th year med student. And interestingly enough, I actually loved my surgical intern year. So that kind of actually, to be very honest, made my 1st year of radiology residency kind of a challenge, because it was such a shift between pace and responsibility and what the day in, day out life looked like. But I mean, clearly I'm still sticking through to IR, but I definitely do feel like surgery is also a good fit for me. So it really depends on, you know, each individual's personality and kind of what you see, what you gravitate towards. And lots of other great fields out there. Some people think, oh, like IR is less work than surgery, but, you know, honestly, not always. It really depends on what your future practice looks like. But yeah, for me, it was a good balance. It is a good balance of, you know, patient interaction, procedures, and imaging, so.
Fantastic. Okay, I believe that we have another one of our panelists on at this time, Dr. Paytech. If you'd like to just log in real quick and just introduce yourselves, and then I'll move on to the next question for the audience.
Hi, my name is Rina. I'm R2 at the University of Minnesota. I'm sorry, I don't know, my webcam is not working. But I went to Lake Erie College of Osteopathic Medicine, and I'm in the integrated program here.
Okay. All right, awesome. So another set of questions that we've been getting a lot, especially as like most of the audience comes from DO schools. There might be some students from other schools that might not have like a radiology department at their site. But for the panel, what were some of the like major challenges that you experienced in pursuing a career in IR? And what challenges did you face in trying to get residency, to get training experiences, and so on and so forth? So I'd like to kind of start this discussion by actually directing this back towards Rina, if you'd like to start this one off.
Sure. So I also didn't really know much about interventional radiology when I started, and it was kind of by luck that I stumbled upon it at the end of my 2nd year. Then I realized during my clinical rotations how difficult it was going to be for me to get actually experience in the IR suite and doing rotations in IR. So to kind of circumvent that, I did diagnostic radiology rotations as I could, and went to the angio suites to introduce myself. And another difficulty that we have is that we don't have the resources available at a lot of our schools to have the research going on and med student involvement, especially. And so I found that to get involved in research projects, I had to reach out to residents at other hospitals that were kind of near me geographically, and also through SIR to get involved with projects. I think that's really important because you build those relationships and also you get a greater understanding of what the field is.
Yeah, excellent points. To kind of just continue on that, Navjit, did you have any kind of challenges that you remember that you experienced as a medical student in trying to get into residency?
Yeah, sure. So, you know, one of the challenges of, you know, my experience, I guess, was the lack of a home institution, and by ways, lack of a home interventional radiology department. So again, as mentioned, there were challenges, you know, for example, with finding research or projects to jump on, showing interest. You know, one of the things that I found really valuable, you know, in terms of well, one of the things that I basically found really valuable was joining the SIR and actually becoming active in the RFS section. And so actually, thankfully, Dr. Vaticancheri is on the panel, or on the panel as well. And I got linked up with Rocky as well as Karthik on the critical care service line. And we were able to, put together some projects basically putting together, for example, the point of care ultrasound project that we have on the clinical resources. So that, joining the SIR RFS is incredibly valuable. You learn so much about the field. There's opportunities to contribute. And there's always projects going on. There's landmark trials, for example, or rotation guides. So I found that pretty valuable. The years below me, another thing you can do is try to join up with or reach out to an institution that's nearby you. So for example, Henry Zato, he's a year below me. He reached out to UCSF and was able to get a publication in JVIR with his work with Dr. Conrad and Dr. Kumar over there. So it does take a little bit more work, but I think the key to success in this field, or at least in terms of overcoming challenges, is networking, which unfortunately is kind of it's limited now because of COVID and the virtual events. But I think things should hopefully be returning to in-person pretty soon, and I think that'll be really beneficial.
Fantastic. And then kind of just to segue from this question, so there are the challenges about kind of pursuing IR as a DO, and kind of the limitations on the experiences that you can pursue at your school. But on the flip side of that, did you, in your training for the second, third, fourth year in medical school, did you notice that there was any significant major opportunities that existed to you as a DO student, whether it would have been a customization of your elective training schedule, trying to find very personalized training experiences in the community, or what things did you notice that may have been impressive to residency and admissions committees and that you had to do in pursuing IR? And this could be, I'll just open this question up to anybody on the panel that would like to kind of speak on this topic.
Sure, I can take that. So I personally felt like this kind of leads back to the prior question of the challenges with finding opportunities. It's true, it's there, and I think as a generalized statement across the board for most DO institutions, it can be a struggle as a student. However, I think through having those obstacles and trying to figure out opportunities on my own, that really built a lot of character development and being proactive. And I think that really came across when it came to either my away rotations or even currently in residency. Granted, I think maybe not everyone has similar characteristics like that, but I think definitely that was something that, out of my program, it seems that I still tend to be very proactive in trying to be involved with how our program is run and trying to further develop it for better. And so, yeah, I think even though the challenges exist, I had to kind of acknowledge that, yeah, honestly, I might be able to sit here and kind of I think initially I really kind of complained about how, our school didn't have opportunities set up and they make it difficult. But once I kind of acknowledged that and was like, okay, well, that's not going to change. I have to either do something about it, or otherwise doors are just going to stay closed. But you got to find your ways to open up doors, or at least find doors that are open. So
excellent points. Any of the other panelists have any other thoughts on the opportunities that might exist for DOs
I think you have to make your own opportunities, unfortunately. You know, whether that's through mentorship or reaching out for projects or SIR, there's lots of ways to make those opportunities. But I think there's a good point made that doors are going to be closed unless you try to open them. So.
Awesome, fantastic. So I'd like to keep things moving along. Another major question that we've been getting from a lot of the audience members is just kind of your thoughts on what is a day like for you every day, Monday through Sunday, whatever it might be. When you coming into your shifts, what kind of cases are you working? Just your thoughts and experiences up to this point. And so I'll open I'll start this section off by actually sending this back over to Rina, if you'd like to start this one.
Sure. So I'm in my R2 year, so I'm on my diagnostic rotations mostly. I show up at work around 7:30 and start reading on whatever rotation I'm on for that day. We at our program have noon conferences, which are, you know, dedicated, protected didactic time, where staff or senior residents may give lectures on whatever topic is supposed to be for that day. Then we go back to reading our images until 4:30, and then we go home. Today was a call shift for me at our trauma hospital, so I am still at the trauma hospital during this conference right now after my shift. During our IR rotations, we get to the hospital around 6:30, pre-round on any of the cases for the day, and if there's anybody that we've admitted for cases from the previous day or days before, we'll go upstairs and see them, and then we'll do rounds as a department where we go through all the cases and approaches, so everybody knows what's going on, and then we just do cases until the day is done.
That's fascinating. Yeah, thank you for your response. And just a reminder to the audience members, you do have access to the chat bar and also to the questions. So if you have any comments or questions at this time, feel free to pipe them in there. I know Dr. V is monitoring that chat right now, and he's putting in some very valuable input at this time. So if you do have other comments that you'd like to put in right now, feel free to shoot them there. And then just to keep this one going along, also I was wondering, Millie, if you could give your thoughts on kind of just like what a day is like for you as an IR resident.
Sure. So I think being on your diagnostic radiology rotation is very different from being on an IR rotation. For the most part, diagnostics for how our program is set up is essentially a 8 to 5 shift during the regular day. And then if you're on call, then you tack on from 5 till 9 p.m. I'm also currently on call, and we do a 13-hour shift over the weekends. And then we have scattered months of overnight call, and every program is set up a little bit differently. For us, we have the opportunity to take solo call overnights, so essentially we don't have any attending backup, and we get to put on our big boy and big girl pants and be you know, our call counts. And for IR side though, most days run, I'd say about, I don't know, I think we come in around 6:30 or so. Typically the end of cases probably around 6 or 7. And then of course the residents always end up staying later to finish up dictations. So it can get pretty busy. And to a certain degree, very similar hours to certain surgery rotations. But to me, the time just flies right by. And then, so in addition, even though you might think, oh, like an 8 to 5 job on diagnostic radiology, that sounds so chill, you actually spend quite a bit of time afterwards studying. But it is nice in the sense that you know, it's not like you're necessarily confined at work. So your work hours are shorter, but I think in general, counting the number of hours that, you know, I had put in during intern year, and now it's pretty much about evens out if you're counting in the amount of study time. So yeah.
Thank you for those thoughts. Sagar or Navjit, any opinions on your experiences so far through residency?
Yeah, so I've been doing primarily diagnostic rotations. For us, we come in at 8 to 9, and 12 to 1 are lecture times, and then 1 to 1:30 is like lunch or resident wellness time every day, which is nice, just to decompress and like play some board games. So we end up reading, I guess that's then like 5.5 to 6.5 hours of a day. And for IR call, it's 1 weekend a month and 1 weekday a week for the ESIR residents who are on IR and the integrated residents after PGY 3 year. I've been voluntarily taking call just because I don't want to forget everything I learned from surgery, and I want to get, you know, a good one-on-one time with the attending. So when I do rotate through IR, they feel comfortable with me, you know, from the get-go. And for that, you know, we take home calls. So I have been getting, you know, it's a mix. Sometimes it's a call for, you know, just like a heads up kind of thing from the ED that doesn't amass to anything, but you have to, you know, look at all the imaging, call the attending, you know, well informed on the patient. But you know, it's all from home, and we cover 3 different hospitals in the Philadelphia area. So when you do go in, you know, commute time does factor in if you're going from hospital to hospital. But I'd say in the last 3 months, just picking up those IR call shifts, I've gotten like 40 or 50 cases. So different workflow, you know, than the rounding. But yeah, and the diagnostic days, I completely agree. You're only there for 8-9 hours, but you sink in another 2 or 3 at home studying. So the hours do kind of average out, I'd say.
One of the differences also with DR is that when you're there, you're constantly there. There's always cases that are coming through. There's no real downtime. So, you know, it may seem like you're sitting in a chair for 8 to 5, but you know, those days are exhausting at the end of them, because your brain is constantly working. You don't want to miss things. You know, you're thinking about, you see something, you're like, oh, what pathology is that? So you're always trying to go back onto your, you know, your knowledge base there. So those days are, you know, I guess it's you know, could be deceiving, especially on call. Call is also quite
Yeah, thank you all for your thoughts on those. So I'd just like to keep things moving along. I'll actually pass things off to our other medical student, Oleg, who's going to be kind of giving an overview of the next few questions.
All right, how you guys doing? My name is Oleg. I'm a 4th-year medical student at Nova, Southeast University. So I'm also part of the Medical Student Council. I'm going to be addressing some of the next questions that are coming up from the students. So the next question we had is kind of what can be done as a 1st, 2nd, or 3rd year medical student to prepare for IR? Specifically, how do you find mentors? What are some electives that you can do in order to help with the learning about IR? And what are the extracurriculars that we can get involved in? And this question will be for Millie, if that's okay.
Yeah, sure. It's kind of an interesting question. So Dr. V, I rotated with Dr. V at Kaiser LA as essentially my first inpatient rotation of 3rd year. I had no idea what was going on. I think retrospectively, it might have been better if I had rotated through my core rotations before, because a lot of what IR does is, I mean, it crosses all disciplines and is is almost like a tertiary type of issues that come up to us. So that might be one suggestion, is to do core rotations first. But honestly, at some point in time, you guys are all med students. You kind of just drink from a fire hose, and you learn in layers. And so, there was quite a bit of stuff that I learned on that first rotation, and then I had multiple additional IR rotations later on at the end of my third year, beginning of fourth year. And so, essentially I just layered my learning. And the other stuff that really helped was also going to conferences. I felt like that was personally my kind of like a special factor to my my experience and journey through IR, going to conferences, and especially the ones that were oriented for med students and residents, because things are explained at a more fundamental level. And also for me, when I attended these conferences, I tried to sit next to residents that I connected to, those who are a little bit further along than myself, so that I could kind of pick their brains and ask them, like, this guy just said something, I have no idea what he's talking about, like, can you explain that to me? So I felt like that was really helpful. Once again, also a lot of Kaiser LA residents who are like my mentors in addition to Dr. V, so.
Thank you, that's very helpful. Navjit, have you had any experience with certain extracurriculars that you found very helpful on your path to IR?
So that's kind of a tough question. Are you, so I guess, is that kind of focusing more so like on in terms of clubs, or in terms of like other activities or societies?
Right, like any clubs or anything that helped you learn some additional information that helped you shine on rotations, or something that you did that stood out on your application that specifically helped you throughout medical school?
Yeah, sure. As mentioned, or as I was talking about earlier, getting involved with the RFS is really a great way to show your interest in interventional radiology. If there's any opportunities for you to get involved with organizing a medical student symposia or a trainee symposia, it's also a great way to get involved. You can reach out to whoever's organizing one that's local to you and ask, hey, is there any way I can help? Is there any way I can get involved? Interventional radiology is such a diverse field, head to toe. You got to know, things about when you're on service. You got to know, basic information about, for example, what surgeries are, or like what the different types of surgeries, for example, because you're going to be managing some of the complications that may occur. You're going to be helping your surgeon colleagues in patient management. So, getting involved with a surgery interest group may be beneficial in your early years of medical school. Any knowledge, I'm a believer of any knowledge that you gain is beneficial. Even if you don't necessarily use it, at least you have it in case you need to reference it later on. So definitely getting involved with other specialties is I think would be helpful. I didn't do it, but in retrospect, maybe I should have.
Thank you, that's perfect. Yeah, we can definitely also, just like you were saying, there are opportunities to get involved with reserves on the website, SIR, at this time. So students are interested, they can also get involved that way, just like you were saying, through SIR. That's a great way to get to know the specialty better. So that's perfect. So we're gonna move on to the next question.
If I could just add one quick thing. Just rebounding off what was talked about, how conferences helped. Just a little, like maybe you guys already know this, but what I did was when I went to SIR as a student, how you can see all the abstracts and notes and posters and who's presenting. I just found whatever programs I knew I'd be interested in on the application site, I mean on the interview season, and I would just find whatever posters, like where they were, what talks were being given by either the faculty or the residents at those programs, and just go up to them and have a conversation with them. I mean, it's work and it's a lot of exhaustive talking, but I think that really helped out. I made it a point to individually talk to people in like 10 to 15 different programs, and then on the interview trail, it does make a difference. So that's something, if you go to a conference, I think you should dedicate a couple hours during the daytime for each day doing that.
That's a really good insight. Thank you for that. All right, so the next question will be another question that we got about applying to residencies. Specifically, is there anything that the panelists wish they knew prior to applying to residencies sooner, such as letter recommendation tips or tips that you can use during interview? And so Sagar, would you mind addressing this one as well?
Yeah, I think you should have a game plan on what specialties you want to have in your letter recommendation, like profile kinda. For me, I knew I wanted some type of operative non-IR, I wanted like a gen surgery or some subsurgical specialty. So I made it a point to get one of those. I thought getting one from some type of internal medicine or cardiology service was important, and you got to keep these things in the back of your head even when you start your first day of some rotation, that a specialty you're not going into. If you think you want a letter from that field, you got to find someone early on and attending that you think would write a good letter and would have good experience in writing letters, and really make an impression on them. And then I think regionally, the way, and I think this comes up in one of the other questions that we'll talk about, is if you're targeting a region and you want to do a rotation, and you're doing an away rotation at that region, that letter of rec, that faculty member attending, he's going to be well known in that area. If you get a letter from someone in a Philadelphia hospital, every other Philadelphia program will know that person, and that letter might hold more weight. So when I was applying across the country, I made sure, I had an East Coast letter recommendation IR that was important for my East Coast schools, same thing for the West Coast schools. And you got to think about that too. So I think, regional IR does make a difference.
Thank you very much. Yeah, that's very important to have a plan, definitely, as you're going into planning your letters. So thank you. Rina, is there anything you'd like to add on this topic as well from your experience? I'm not sure if she's on right now. Is there anything that you found as far as TO friend? Oh, sorry.
Sorry, I was unable to unmute myself for some reason.
Oh.
I think going in, knowing some programs are academic programs, some programs are this like hybrid program where they have residents but originated from private practice, and how that can affect what kinds of cases you see. At my program, we rotate through different hospitals, so we get academic and private practice exposure during training. So coming into the interview process, kind of having an idea of what kind of cases your program is going to do and what kind of practice models you get exposed to, I think is helpful.
Thank you. Yeah, that's very helpful. Another question that we had is regarding the DO-friendly residencies. Are there any residencies that you found that are specifically friendly to DO students when they're applying, or some that you learned a lot while attending those residencies during interview season? And anyone on the panel can address this question.
Really quickly, I just wanted to add a quick tip to the letter of recommendation. Definitely try getting them as you go through your rotations. It made it a lot easier for me. I wasn't struggling at the end, messaging frantically, looking for letters, because I had those, as I was, going through. So just something to keep in mind as you go through your third year rotations. As far as DO-friendly residencies, I mean, I'll throw out, I'm at the University of Arizona. So, you know, we have about 4 to 5 DOs that have come in over the past couple classes. You know, it's at least on the diagnostic side. And then also I know Henry is over at Christianity, and you know, I think it's becoming more of a trend that, you know, that basically there's more holistic review of applications, you know, looking not necessarily at the last 2 letters after your name, but more so what you've done, your experiences, how you've done on your core clinical rotations, whether you've been honoring, you know, the type of worker you're going to be.
Yeah, that's definitely very good to hear for those of us who are DOs who are applying. So, and definitely good to have letters as you're going into the ERS application season, so you don't have to spend much time being nervous about whether you're going to be able to apply in time as well. So it's definitely a great tip. Any other panelists have any other input on this question?
I'm gonna also add to that. I think there definitely has been a push in advocating for DO students, and but I think there is a degree of reality that there's still some more institutions, like there are institutions out there that they will pre-screen, you know, and even though they technically don't say it, and I can't necessarily like label that as, oh, they, you know, screened me out because of the last 2, you know, initials, but or if it's like board scores or whatnot. But for myself, in terms of when I was trying to figure out a program, I essentially looked online and tried to go back to however many classes they have available online to see whether or not they admitted any DOs. And as Navjit said, like I actually rotated at Christiana and I loved it, and they definitely are DO friendly. And I also interviewed at other DO places, DO friendly places, and honestly, I was pretty disappointed in what I saw, I guess you could say. So definitely be aware that even though if it's outwardly may seem DO friendly, like essentially all of the residents were DO at this program that I had visited, that also kind of gave me a red flag in terms of, after seeing the program itself, that essentially wasn't a place that I wanted to be at. And ironically, Loma Linda, I don't think we've had a DO resident for, I don't know, at least like 8 years or something. So even though programs might not have a, you know, a DO resident for a while, doesn't necessarily mean they'll be closed off to it. I was fortunate enough to rotate through Loma Linda, and you know, they got to see me as a person, and I wasn't just a number, you know, a piece of paper when it came to applications. So it's kind of difficult to tell whether or not a program is DO friendly, and honestly, sometimes you just have to take that chance. You know, I'd rather apply and get rejected than not apply at all. So
that makes sense. Thank you for that input. That was very insightful. So we're gonna move on to the next question. The next one is, what are some ways that you found that you can stand out during IR rotation? In particular, how many rotations would you recommend to have in order to match IR? And are there any sites in particular, some of them were already mentioned, but are there any other sites that you would recommend for students to rotate at? This question can be for Rina initially.
Sure. I think to stand out during your IR rotation, I think definitely ask questions. You know, you should be looking up the cases that you want to go into, and you should be asking questions about the procedure if you have any. I think, you know, like at my program, we do our morning rounds, asking to present a patient, you know, maybe one of the simpler procedures or whatever, but asking to present the patient, I think shows initiative and kind of shows that you understand what's going on in the department, and also kind of gets you involved in an earlier stage. And then, sorry, what was the second part of the question?
The second part was how many away rotations would you recommend on average in order to match IR or DR?
Oh, sure. I think this is difficult for me to answer. I only did one official IR rotation because that's all my school would allow me to schedule. I had a few diagnostic radiology rotations that I, you know, made sure I went to the IR departments to introduce myself and get involved there on my off time when I could. So you can get in with one, but I don't think that that's the ideal number.
Thank you. That's very helpful. Sagar, did you have any other input as far as how many rotations you did in general in DR, IR? And is there anything you found that you specifically did that helped you match?
Yeah, so I did 3 away IR rotations. The first one I did was at Kaiser, which for all you guys listening, I really think that if you do Kaiser, you're, especially earlier on, you're set. That's the best chance you have of getting ready for your other IR rotations to really impress. And just put your name out there and get some credibility behind it. So I did IR first at Kaiser, then I did IR at Christiana, and then I did IR at Einstein. The plan I had was to do, you know, regional in the Northeast and 2 places that take DO programs and take, you know, I think you can kind of get a good predictor of any hospital system based on, you look, you know, I'll go regional because I'm from Philly, you know, if you see Penn State or Drexel after a residence, you know, like where they went to med school versus, you know, Brown or Sinai. I mean, let's be real. Like you can tell that one place is going to be a lot more open about your DO background than the other. So I made sure I went to places that, you know, if they had only MD schools, that's fine, but make sure they're, you know, quote unquote middle tier instead of, you know, quote unquote Ivy League. I think it made a difference. So yeah, I recommend all 3. Obviously I'm at Einstein, I love it. I love Christiana as well. And yeah, you already know my thoughts on Kaiser. So yeah, I would recommend 3. Also, I think 3 was a good amount. I did 1 DR rotation in the middle there, just with the guy I was doing research with. It was more of like a research DR shadowing block, but I would recommend 3. I think it's the optimal amount.
Okay, great. Thank you. Yeah, that's very helpful, and it's great information for students who are looking to choose where to rotate and how they should go about planning their 4th year. So thank you for that. Are any other panelists have any other input on this question as well? And we also do have some questions in the chat that we would like to address. They've been coming in as we've been having this panel. So Eric, did you want to look through some of those and address some of the questions that we've had?
Yeah, I can help out with that too. But first, we just wanted to say that kind of concludes our planned section of questions. And thank you to the panelists and Dr. V for being here to share your time and experiences. We also want to say thank you to Sydney Rubin. She's our chair and she helped us coordinate this event. And of course, all the attendees. We kind of realized that the questions function isn't working like super properly, but just keep sending your questions in and we'll get them in the chat and then be able to respond to them from here. we actually have like a lot now, so we can probably just hop into those. The first one that we received was is going to residency at a community hospital versus an academic program have, oh sorry, just skipped down, have a major effect on one's future career. And then feel free, any of the residents, to hop in on that, or even Dr. B, if you have some wisdom to share.
I'm sorry, is the question community hospital versus academic?
Yeah, and how does that affect your career?
From
You take
yeah,
that. Keep going.
Okay, I'll take it. So I think the learning opportunity is different. I believe most academic places are tertiary centers, so you're seeing, you know, more, you can see more zebras. Not to say that it doesn't happen in the community, but I think your variety of cases might be very different. And I think it also, so that's more so on the diagnostic side. And then every program is very different. So if you're looking at a community hospital, it might be, or a community program, it might be attending driven. That is also very different from being a resident driven program, which Loma Linda is. So for my program, the list is our responsibility, and you take care of everything essentially. So every case is considered your learning opportunity. And in terms of community programs, with the respect to IR, you know, you have to look into, is there ESIR, or if there isn't, are you willing to do an extra year with the integrated track, or sorry, independent track? And honestly, I think now as a PGY4, when I think back on it, I think it's actually not such a horrible idea to do an independent track, just because, well, one, so if you're integrated, you're essentially doing your training all in one program, and you don't really have the option to train at a different place and to get a different perspective and different skill set of techniques. So that's the one downside to it. The upside of it is, of course, you know, I don't have to reapply. But the other side of doing an independent program is that you have an extra year of diagnostics, and I think for those who are thinking of doing both diagnostic and interventional for your career, that probably is beneficial. Otherwise, you might have to do like an additional fellowship year to be able to feel more comfortable in certain things. So it kind of just depends on what you're looking for. And the other part to kind of consider is, you know, how well does the program prepare you for boards? So that's just another thing to ask, I guess, the residents at the community program. But I think every program is different, so I think it's important to ask those questions for the residents during, you know, the interview trail, or if you meet up with any of these residents. So.
We do have like a few other questions. One interesting one that popped up in the chat that I'd like to just open up to anybody on the panel that would like to answer this. We have a third-year student that is currently curious about applying to IR, but it doesn't sound like he or she might be quite certain about it yet. And it sounds like that in making this decision, it's kind of about kind of getting a determination about what is the quote-unquote personality of interventional radiology. And so for you, for attendings, for other people that you've seen in this field, kind of how would you describe what the personality is of an individual that would like to go into interventional radiology?
I think you'll see a dichotomy when it comes to the attendings. Some have the very, I'm just a proceduralist, I want to stay downstairs, get referrals and just do stuff down there and not, be as clinical as others. And then you'll get the very, aggressive, I'm going to go after like PAD or something, whatever's red water at your hospital. I'm going to make sure I'm rounding. I'm going to make sure I have a clinical presence, and I'm going to put in the extra time to do that. And I noticed like a sharp dichotomy between the two. And then in terms of the residents, I'd say the same. There's a varying. It's a spectrum. Some residents really make it a point to try and learn all the clinical ins and outs of a disease process and the treatment algorithm before it even comes down to the step that IR comes into it. And I think it's all self-driven. I think you can probably get away with knowing very little of the clinical decision-making branch point before it comes to IR, and you can get away with that if you just know a lot about what you're doing in the procedural suite. So I think there's a lot of wiggle room there, which is nice. And is a little bit more, inviting to a lot of different people. If you do vascular surgery integrated or CT surgery integrated, you can't really have that difference in how proactive you're going to be.
Interesting. Any other thoughts from the other panelists on that question?
Yeah, I think you'll kind of see a variety of personalities as you do OA rotations and also as you interview. There are people that are, I think maybe it was through JVIR, they had an article like you're a surgical radiologist or you're a radiologist that likes to do procedures. Like, I think people kind of fall into 4 types of personalities, and it kind of becomes more clear as you're going through, and likely your department will have a variety of those personalities, and you can kind of see where you're at.
Okay, great. That was very insightful. Thank you, guys. Another question that popped up in the chat came from one of the students, and they were asking about how is IR going to evolve in the next 5 to 6 years, in your opinion? And since IR is definitely a rapidly developing specialty, where do you see IR going in the next 5 to 6 years? And anyone on the panel can answer this one.
Is Dr. V still there? I was going to see if I'd be interested in hearing his opinion with it too.
I would too.
Yeah, hi, I'm here. Yeah, I think it's rapidly evolving into training and expanding into multiple different beds. So where, in 1960s, we're mostly doing arterial work and obstructive disease. We progressed to, oncology, and now pain and spine interventions and MSK interventions. So I think we're getting more and more organ systems under our belt. So that's the main shift. I think clinics will be a must as it gets so complex, and follow-up of some sort will be required. So it's going to take time, because what's happening in the private sectors and even the academics facilities is getting kind of clinical acumen up, getting dedicated clinic time and space and infrastructure to do what should have been probably done 50 years ago, but it's now, the last probably 5 years, become more and more of an impetus for the specialty. So I think those are the 2 main places you can change. And training will continue to change as we have more and more to learn in less and less time.
Awesome, thank you. And actually, another question that might be good to point towards you, Dr. V, is a lot of people are asking about step one being pass-fail in this coming year, and so they're kind of wondering how that's going to affect applicants in general, and how especially DOI applicants might appear more competitive or try to work to be more competitive with one of the ways that we normally would have kind of stood out now being gone.
Yeah, I think that's a really good question. I think not just DOs, but foreign medical graduates are going to struggle with this thing, because one of the things that did help a lot was the step one to kind of differentiate yourself from other applicants. And so we don't know how we're going to answer that, what the answer is going to be. Probably step two to some extent, but in general, people score a lot higher in step two than step one. So it's not as much of a kind of a bell curve, so to speak, or skew. So it's harder to kind of showcase yourself. So I think what many have said is, I think Navjit, Millie had suggested is, getting your word out there, getting on Twitter, getting to the meetings, getting on SIR, MSc, getting involved, setting up symposia are going to be the key things to get your name out there. Multiple I think Millie did a great job going to multiple interventional rotations and getting on kind of on the block early. That really definitely helps a lot to get your word out there, because you have to showcase that, hey, I'm really passionate about it, and those are the ways to do it.
Gotcha, thank you. And that actually kind of segues into a couple quick questions that we had. One was, how do you register or join SIR? You can go to sirweb.org, and there should be a join button on the top right corner. Dr. V and maybe some other people helped fight for students to get free registration, so that's a good resource and a good place to start. And then a couple of people mentioned or asked for the residents' contact information. We're actually working on a DO directory, so we'll be able to send that out shortly, and hopefully share all the residents' information here and other DO residents who couldn't make it but are willing to answer questions and provide mentorship. Just to quickly answer those. And then the next one is an IR letter of recommendation. I guess these are all for Dr. V kind of, but is an IR letter of recommendation from a rotation that's mostly an observership still useful? My opportunities are limited due to a lack of a home program and other limitations, including COVID.
Yeah, I mean, it is definitely better than no letter from IR. Certainly, like you said, the busy places that you can get a letter from, like Christiana Care, et cetera, that that you're going to be heavily involved in the rotation is what they want to see. Surgery letters I find very useful, especially like vascular surgery or something that's kind of comparable in nature. If that letter says, hey, I would really love this person in our specialty, that's a good sign. So those kind of letters are what we're looking for.
Oh, thank you very much. Another quick question that has been coming into the chat is just kind of more a logistical question. When applications start coming up, there was just a question about how many programs did the panelists apply to, and what would you recommend for students out there?
I applied to 3 to 25 IR programs, 40 DR programs. So it's like 25 of the corresponding DR programs, then 12 to 15 who didn't have integrated IR. And then I did 20 prelim surgery. I only did prelim surge. I would recommend that amount. I think it was a good amount. Kind of covers the bases. So yeah. Was there another part to that question, or was that?
No, it just looked like that was it.
Yeah, I probably over applied. I think I applied to, I don't know, like 50-ish IR programs, and then obviously there are corresponding diagnostic programs, and then probably in the end about 45 DR programs. it was probably over applying, but I would rather over apply than under apply.
Yeah, same here. I essentially over applied. I think I was part of the second or third class of integrated IR. And so essentially I applied to all IR programs, and then I don't remember the number of diagnostic programs. And then for surgery, I think I only applied to a couple of prelim years, to be honest, because I figured these would be prelim years and there'd be something open if I didn't match to one. And that wouldn't really be such a big problem. But yeah, my perspective was similar. Like, you know, I didn't want to have any regrets. Like, I don't want to close the door on myself prematurely. And, you know, I watched friends not match, and unfortunately it is a problem of being at a DO program, and also of course MD programs, but you know, I didn't want to be in that situation, so I kind of thought of it as, you know, this is investment for myself into the future, so no regrets in that sense.
I agree. I was on the over apply end of the spectrum as well. I think the match the year before ours kind of scared me a little bit. But yeah, I mean, especially with the virtual interviews, I mean, that's a whole nother debate about, you know, the quote ethics of it. But, you know, everyone else is over applying. You might as well over apply. This is your one chance.
Thank you. Those are really great answers, and will be very helpful in students applying and planning their application season in general. So we have one more question. It'll be the last one probably for this panel. So the question is there anything that you wish you knew prior going into IR residency, and something that would have helped you prepare better for it? Maybe something that you wish you learned, or something you wish you did prior to residency that would better prepare you for it? And any of the panelists can answer this one.
Yeah, take every opportunity that you can to learn. You know, don't waste your fourth year. You know, it's an incredible opportunity where, you know, especially it depends on your institution, of course. For mine, we were able to do elective rotations for all our required or basically do away rotations for all of our required fourth year rotations. So it was an incredible opportunity to, you know, go to a bunch of different institutions. I mean, it's easy to kind of relax during fourth year, but really you want to, you know, keep your knowledge base up, and you know, take every opportunity that you can.
Any other panelists have any input on what they wish they did prior to starting their residency in order to help them kind of be more prepared for it?
I guess question was before you start your IR or DR residency. So I would say when you're in your intern year, especially the first 6 months, I wouldn't worry so much as, oh, how's this gonna, you know, apply to my future IR, you know, residency. The first 6 months, especially, I just immerse yourself in, if you choose to do surgery or medicine or whatever, you know, TY or whatever rotations you're on, just focus on that, because it's more important you're a good resident and you have good foundations for that intern year. I made it a point not to, you know, in the beginning I was getting too preoccupied with, oh, well, you know, I just want to care about the IR, you know, imaging or whatnot. But just take a step back and immerse yourself in that intern year. And then, you know, the next 6 months, especially the last 3 months, you could really start, you know, reading diagnostic books on the side. But like Navjit was saying, just prepare for, you know, the last couple months of fourth year. Just get ready to be a good intern. Don't worry so much about IR is what I would say.
This isn't really, I guess, something that I wish I knew, but one of the best advice that I got was, I think actually from Dr. B. For those of you who are for sure going into IR, the advice that he gave me was to learn how to work the backbench and essentially learn how to be a tech. And the thing with doing, I did like, I think 5 IR rotations, OA rotations, but essentially at every place that I went to, like nobody knows who you are. No one knows if they can trust you. So for the most part, they're not going to let you touch the patient and like do the actual procedure. But what you can do is participate, jump in the cases, and work with the techs. You know, help out with the cases in terms of that role. And that way you build the trust of, you know, the resident, of the attending. They know that you know how to handle wires and catheters. Because the main thing is they definitely don't want you dropping, you know, a catheter that costs like a couple grand. So the best time to really play and work on your skills is actually after a case finishes, because then, you know, it's fine if it drops on the floor. We're done with the case. But that's like the golden time for you to play with the equipment. And I even do that as a resident myself. And it's actually kind of surprising. I'll tell that to some med students as a piece of advice, and they'll just simply walk away. So, you know, take what opportunity you have to make it your own. So.
Aleka, that's incredibly valuable advice, and it carries forward into residency as well. Like, you know, even if you're away from the back table for your intern year, you'll be surprised how quickly those skills came back from. I still remember, you know, during med school, during a couple of rotations, I always used to try to burst the balloons because I thought it was really funny. So what you do is you basically put the balloon inside of a syringe, and then you just inflate it really high, and it's kind of fun to watch.
Also, the benefits of, you know, owning the back table and interacting with the techs and nurses is that if you match where you did your rotations, when you come back, they know who you are. You know, like my first IR rotation as an R1, they remembered me, and, you know, they already knew that I knew how to handle a wire. You know.
Awesome. Thanks, everyone. And then some general advice from Dr. B in response to all these questions that I'll just kind of read off. You mentioned 2 or 3 VIR rotations, vascular surgery, ICU, and cardiology, and especially consults are all high yield for VIR. VIR has much less clinical training during PGY 2 through 4, so it's important to get that training and understanding as a solid foundation. You mentioned get a strong surgical internship. Don't just gather data, but figure out what your assessment and plan are. Know the disease, learn anatomy in every rotation you're on. Study an hour of anatomy every day for 4th year and intern year, and then and own the back table. Introduce yourself to everyone in the room. And know the patient's clinical history, round on patients after your surgery, know the steps of the surgery you're scrubbing in on, and that's it. We have a couple more questions coming in, but out of respect for everyone's time, we'll kind of wrap it up here. Like I mentioned earlier, we have a DO directory that we're working on, so we'll hopefully be able to send that out shortly. You can kind of send your questions to the residents directly. And then we'll also have a DO attendings panel. We had some questions come in about future job prospects and kind of career planning, and so that'll be a good time to bring up those questions. But that'll probably be later on in the year, like after interview season and match and all that.
So I mean,
Real quick, that one question is a really good question. If a program that you go to doesn't provide training in a certain procedure, can you learn how to do the procedure post-residency? I think the procedural aspect is probably the easy part, but the clinical side is much harder, right? So for example, PAE, technically, I mean, it's certainly trickier than a lot of other embos because of the collateral circulation, et cetera. Once you get the anatomy down, it's pretty straightforward. But when you're seeing them in the office, pre or post, figuring out what to do with the PSA, sometimes they have erectile function issues. There's a slew of other things. What are the other options? Resum, holmium, laser, tuna, TUIP, TERP. What are the ramifications of each, and counseling on that becomes pretty hard. PIRADS. That's what becomes a challenge, not the procedural aspect. Sometimes the peri-procedural care also can be tricky. Thyroid ablation, same thing. It's pretty technically straightforward. You just kind of avoid the laryngeal nerve and the vagus nerve, and you ablate. Pretty simple for an interventionalist, but now I have to go back to TSH, T4s, the different types of Bethesda too, Bethesda staging, what the natural history of thyroid nodules are, how is it manifesting, what are the ramifications, et cetera. So that's where it becomes challenging, to navigate, so it's a whole different disease process you have to learn. The procedure is easy, the disease is hard. That's why you want to get a strong foundation. Your fourth year med school and your intern year and third year med school, really surgery and medicine should be the key ones. You should really get down. Heart, lung, liver, kidney, brain, get it, own it, memorize everything you can, do as much exams as you can on the patients, and get very comfortable and familiar with the cardiac exam, the pulmonary exam, et cetera, abdominal exam, and the pulse exam. So when you go to your fourth year, it's all kind of second nature as opposed to you're just learning it. Yeah, so I think those are a couple of key things.
Awesome, thank you. And with that, thanks everyone for coming, especially the residents and Dr. B, and obviously you, the attendees, because without you, we wouldn't be able to have this. Yeah, everyone have a good rest of your Saturday night. Take care.